Bye. Welcome, everybody, to Knock Knock Eye with Dr. Glockenflecken. Love a good eye pun. It's the only pun I'll tolerate. I'm not a big pun person. Kristen, my wife, she's she laughs at all the puns. I just kind of get sick of them after a while. But with eyeball stuff, I kind of have to do it. It's right there. And anytime you say eye, it could be a couple different things, and it's too obvious, too easy. And so I do appreciate a good eye pun, so much so that I have named this series of episodes after an eye pun. So Knock Knock Eye, this is the weekly show where I get to talk about ophthalmology. All of you have been clamoring for eyeball knowledge. You want to know everything there is to know about eyeballs. Of course, this isn't true. I'm just projecting, but I'm going to assume it is true. You're here, you're listening to me, and we're going to talk about eyes. Now, last week was the first episode, the first time we did the Knock Knock Eye, where I talked about open globe injuries. It was a harrowing tale. We learned all about the ins and outs of diagnosing and treating and how to avoid eyeball injuries. Well, we're going to continue on with our series on pants patients. Again, every week for the next few weeks, I'm going to be talking about a different type of pants patient. So, what is a pants patient? Just let me remind you. This is a patient that whenever the patient comes in the emergency department, the emergency doctor or whoever it is, they call me, and sometimes what they tell me on the phone about the patient results in me putting on my pants and immediately coming into the emergency department. So these are the true emergencies of ophthalmology, the pants patients. All right, I'm putting on my pants. I'm coming in. Doesn't matter when it is. It is overnight, 2 a.m., 4 in the afternoon. It doesn't matter. I'm coming in. I'm going to see that patient. It doesn't happen often, but when it does, it's serious. Okay, so today, our pants patient is the chemical burn. We're talking chemical burns today. This is one of the most dreaded things in ophthalmology. They're often very difficult to treat, difficult to manage and evaluate. So we're going to go through this. So our patient today, and again, these are our, I'll just start saying our fake patient today, because it's not a real patient, but it's representative of what happens when patients come in with chemical injuries. So our fake patient today was working on a car and had battery acid explode in their face. How that happened, I don't know. I've seen it happen before. It's happened with a patient before. It happens. There's exposure to battery acid. I do not know enough about cars to tell you how battery acid could explode on somebody. I assume it has something to do with opening a battery or dropping a battery, or is there some situation? Any car people want to weigh in on this? How do you get battery acid in your face? Because it's happened before. Not to me, but to other people, often when they're not wearing safety glasses. But this is another thing, because we talked a lot about safety glasses last time with regard to protecting yourself against projectiles. With liquids, sometimes it's different. Yes, obviously, when you're working on a car, you're doing anything, again, where a projectile could come into play, including acid, you want to wear your safety glasses. But I've certainly seen patients come in who were wearing safety glasses, still got shot with some kind of chemical, and it got underneath the glasses, it still got in their eyes, and so it's not, a fail-safe type of thing. So this patient, battery acid. Let's just go through the different types of common chemicals that we'll see that patients get themselves into trouble with. All right, so we'll start with the acid side of things. Sulfuric acid. That's what you find in batteries. So if someone gets battery acid, they're talking about sulfuric acid. Bleach. Bleach is sulfurous acid. I'm taking you back to your chemistry days, you guys. So if you've never taken chemistry, then you'll live a longer life because the stress of trying to learn chemistry takes its toll on an individual. So Bleach is sulfurous acid. Hydrofluoric acid is a much more rare but more devastating type of acidic injury to the eye. Vinegar, acetic acid, a mild acid. And then sometimes with swimming pool chemicals, you can get hydrochloric acid. So I think hydrochloric acid is used in like pool chemicals. So those are probably, I'd say, like 99% of the types of acids that if you have a chemical injury, those are going to be the most common ones. And so I'm going to talk for a bit about what chemicals do to your eyes, because that's a really important distinction here when we're talking about chemical injuries. And then we'll talk about how to treat a chemical injury. So we'll start with acids. You would think, and a lot of people think that like that is the worst thing, like hydrochloric acid, sulfuric acid. I've seen movies. Like, isn't that what the alien blood is made of? Isn't that acid? It's eating through everything. It's going to eat through your face. It's going to eat through your eyes. Not necessarily. In fact, most acids don't eat through your eyes. In fact, if you had to guess what's worse to get in your eye, acid or a base, most people would say acid. It's actually a base, and we're going to get to bases in a second. But a basic chemical is much, much worse for your eyes. So this is why. When you get an acid injury to your eye, the surface of the eye, what that acid does, it denatures, it destroys all the surface proteins. So that means the surface of the cornea, the epithelium, the top layer of cells on the cornea, the conjunctiva, the top layer of cells on the conjunctiva. So it denatures, and then those saponified, fats and the denatured proteins and things, all the surface tissue that's disrupted, that's affected, it actually acts as a barrier to prevent the acid from continuing to go deeper in the eye. With the exception of hydrofluoric acid. Hydrofluoric acid is the worst acid. That can actually keep penetrating through the eye. But when I hear on the phone, it was battery acid. My initial reaction is, that's terrible, but also, okay, this eye can be saved. It's probably going to be okay, because those types of chemicals don't penetrate deeper into the eye. So that's acids. Bases are a whole nother story. Okay, so let's talk about what are the most common bases that people get in their eye. Ammonia. Ammonia is one of the worst. Fertilizers, cleaning agents. You have it under your sink. A lot of people have pneumonia in the house. Refrigerants, those types of things. Bases. And these are high on the pH scale, right? These are like pH of 10, 11, 12. How high does it go? 12. I don't know. All right, another one. Lye. Lye is another one. So drain cleaners. So Drano. It's going to have lye. It's going to have the harmful basic chemicals. Also, another thing you may not realize: airbags, deployed airbags. There's lye in some of the powders, some of the things that are with airbags. At least that was the case. I don't know if that's changed. Any car people want to weigh in, let me know if there's still like lye and the like lye powder and stuff in those airbags. So anyway, I've seen chemical injuries from airbag deployments. Magnesium hydroxide's one from like sparklers, fireworks, flares, that lights up really bright. That's magnesium hydroxide. Lime is another one. So plaster, mortar, cement, those types of things. You get that in the eye, that's lime. That's really bad. So those are all really, I think I hit most of them. I can't think of any more actually. There's other basic compounds, but those are probably the most common. And whenever I hear on the phone that it's a basic compound, I'm like, that's like not even a pants. That's like a no pants patient. Like I'm not even bothering to put my pants on. I'm just coming in to see the patient without pants. And everyone's just going to have to deal with it. It's that significant of a problem. So let's say you're on the job, you get a chemical injury. This is an OSHA thing. This is something that's drilled into everybody who deals with chemicals, drilled into your head. All right, the first thing you got to do right away, as soon as humanly possible, you flush the eye out. And you flush it like a good 10, 15 minutes. Like you want to flush, eye wash station, whatever you can do. Flush it as much as possible. You want to get any of that chemical out, any kind of material that could have chemicals soaked in it. You want to get it out of the eye. So you flush right away. The biggest prognostic factor with chemical injuries, how quickly the eye was flushed out. You gotta flush out the eye. All right, you have to do that, and not just real quick, not just like splash it in your face. All right, you gotta get your eyeballs into one of those, those eye wash stations that look horrifying, right? Because they have like the water spouts that just come and you just like right there in the eyes. That's what you got to do. You got to just pour water. Go nuts with it. All right, just really get your big jugs of water. You just pour it on your face. All right, you got to get that chemical out of the eye. Have I made my point clear? All right, so first thing, that's before you even hit the hospital, right? You're flushing out your eyes. And then, especially with any kind of like highly acidic or highly basic compound, all right, you gotta come in. If you don't know exactly what's in the compound, what's in the what chemical it was, you got to try to get that information. That's really important information. MSDS sheets. While you're being taken to the hospital or you're in the ambulance, all right, have one of your coworkers pull the information about what the chemical is, what the chemical makeup is, what the pH is. That's really important for us to know. It's really helpful to know what the chemical is. So you get to the hospital, all right, the first thing they're going to do, guess what? They're going to irrigate your eyes. They're going to pour more water on you, all right, because it's never enough. All right, however much you think you've irrigated your eyes, you're going to get irrigated again. Actually, the first thing that they're going to do, and what they should do, wherever you end up, whether it's an eye clinic or the emergency department, is check your pH. So we've all hopefully seen pH paper, unless, of course, you never did chemistry. But pH paper, basically what you're going to do is they're going to put it right on the tears, right on the surface of the eye. Just kind of touch it right there on the pH paper. And it should be physiologic. That's normal, 7 to 8, somewhere around there. But if it's with obviously with a strong base or a strong acid, if there's still chemical on the eye, it'll be reflected in the pH paper. So you get that pH right away. Actually, that's what you should do for healthcare workers. Do that before you start irrigating, because once you're irrigating, you're getting other chemicals with other pHs in there. So check the pH, figure out what it is, and then if it's abnormal, if it's physiologic, well, fantastic. The patient's probably going to be fine. But if it's abnormal, if it's highly basic or highly acidic, you start irrigating. This is when it gets horrifying, all right, for people that are not familiar with the chemical injury irrigation process. We use a thing that's called a Morgan lens. Now, if you guys seen the Saw movies, like Jigsaw, like it makes the trap for like horrible people. Well, this is similar in some ways. All right. It looks terrible. It's really not too bad, but it's not comfortable. Not quite as bad as a saw trap, but depending on who you ask. So basically they're called Morgan lenses, and they're like big plastic contact lenses. All right. They go in the eye. They're huge, so they're hard to get in the eye sometimes. So you numb up the eyes real good. This is how in the hospital, this is how we will irrigate your eyes. We'll numb up your eyes so you don't feel it. All right, real good. Lots of numbing medicine. We'll put these big, if it's a bilateral, obviously we'll do both eyes. If it's just one eye, then we'll just do one eye. But we put these big, giant plastic lenses in the eye. Okay, they're sitting on top of the eye, underneath the eyelids. Those Morgan lenses they have a tube, like an IV tubing, attached to it. And at the end of that IV tubing, we have a bag of saline, of normal saline. And so we will flush. And honestly, as far as the type of fluid that you use to irrigate the eye, it doesn't matter so much. Like we need fluid. We need getting on. So we use BSS. It's a special type of fluid in the eye clinic for the eye. It's balanced salt solution. You can use normal saline. I think the pH isn't great on that, but it's better than nothing. So you'll attach an IV bag to the IV tubing and just squeeze that bag and run it through those lenses. And so you have this constant flow of irrigating fluid that's going through the IV and directly hitting the eye. All right. That's how we irrigate the eye. And the reason we do it is because it's direct irrigation. We know it's getting onto the eye to irrigate. And we can run bag after bag. Honestly, I'm not exaggerating. Sometimes we run 8 to 10 liters through that if it's a really severe burn, because we have to normalize the pH of the eye. Otherwise, the eye will continue to deteriorate. So, in addition to that, we also have to make sure we get any debris that maybe has splashed into the patient's eye as well, because if there's some kind of debris, dirt, whatever, that has chemicals soaked in it, that'll continue causing problems. So I told you, this is going to get gross. This is terrifying. I know it's horrible. We use like a Q-tip to just sweep underneath the eyelid, make sure we get all the debris and stuff out of there. So we're irrigating the eye. We run like 3 liters through it. Check the pH again. All right. Patients, sitting there listening to music, sometimes screaming. It's an uncomfortable experience. I will acknowledge that, but it's also what we sometimes need to do to protect the eyes. Okay. And a lot of times we can do sedation too. So we do give sedation. We give as much pain medication and things as we can to make the patient as comfortable as possible. But it does suck. It's rough. It's rough. I hate doing it. And a lot of times these are also done in the burn units as well, because obviously they're used to, this is just a different type of burn, chemical burn. And so whenever I get the phone call of a chemical injury, that's immediately I'm giving these instructions like, hey, get some Morgan lenses, either get the patient up to the burn unit or right there, start irrigating and continue irrigating until I show up. Check pH first, but then irrigate. So that's what I say before as I'm, again, getting my shoes on. I have no pants, but I will wear shoes. And getting into the car, going to the hospital, they're irrigating. And then when you get a call of a chemical burn like this, it is your night. That is, you will be there managing this type of injury for quite a while, because there is a series, especially for the basic injuries. There is a long protocol of specialty drops, vitamin C drops, steroid drops, antibiotics, doxycycline. There's lots of things that you can do to help stabilize the eye and prevent further melting of the eye, because that's what you're concerned about. Those basic chemicals, they'll just go deeper and deeper and deeper into the eye until it eventually gets through the cornea and starts affecting the inside structures of the eye. So there's a reason this is a pants patient or a no pants patient. I'll try to distinguish between the two. Try to distinguish. I'll tell you what diseases I will come into the hospital naked. I don't know, but whatever. So anyway, you know what I'm saying. So it'll take hours. This is a really severe, potentially blinding problem. And so we have our protocol of specialty drops that often require specialty pharmacy, and we'll continue to monitor those patients. And again, the basic ones are the worst. The acidic injuries, most of the time, they're okay. We irrigate them, get the pH back to normal, probably give them a topical antibiotic because they probably have a big scratch on the eye, but they'll do fine. The basic injuries, they're tough. They take a long time to manage. And one of the telltale signs of how well an eye is going to do. And so if you're examining an eye, if someone comes in with a chemical injury, you want to see that eye be red and angry. those blood vessels, all like the really beet red eyes because of this chemical exposure. If the eye is beet red and angry appearing, the patient's in pain, but you see all these blood vessels, that is like a sigh of relief for an ophthalmologist, because those blood vessels, that eye still has a blood supply. If you get a severe enough chemical injury to where it's a basic compound and you look at the eye and it is white, it is completely white, that is a bad sign, because that chemical has destroyed the blood supply, destroyed it. There's no more blood vessels left. And you obviously you have to have blood flow to heal an organ. And so if we see bright, even though it sucks because it's painful, but if we see all those blood vessels, that's good. We like seeing that. And so that's something we look for. We call it limbal. We call it, I'm trying to come up with the word, limbal ischemia. So the limbus is the edge of the cornea, right where the cornea, the clear front of the eye, meets the white part of the eye. And so that's so we look for blanching of vessels. We look for signs of ischemia. And yeah, just, we have to, we become real tight with patients that have chemical injuries, because we're going to be seeing them like every week for months. And it's sometimes several times a week, because we got to try to save that eye. So there are some very serious things that happen in the ophthalmology world. And so that is the pants patient for today: chemical burns. All right. More than you've ever wanted to know. And if you have, for any of these diagnoses and things that I've talked about, if you have follow-up questions, let me know, and I can address them at the next episode. All right, it's time for the Don't Do That eyeball tip of the week. So every episode, I'm going to present you with a thing that you don't do. All right, this is coming from a board-certified ophthalmologist, so please believe me. All right, don't put things in your eye that are not designed for the eye. Now it seems obvious, right? But you'd be surprised some of the things that I've seen on social media, and the fact that we're talking about chemical injuries just reminded me of this. All right, if it's not designed for the eye, don't put it in your eye. All right, just a few things that I have seen on social media over the past 5 years. I have seen people directly apply mascara to the surface of the eye. Don't do that. It's not designed for the eyeball. I've seen people there's an entire face group devoted to urine eye drops. People thinking that there's like this thing called urine therapy, where you can take your urine, put it in an eyedropper, and then put it in your eye. Don't do that. Urine was not meant for the eyes. There are better ways of treating anything in the eye. Don't do that. There was a brief, I think it was a TikTok challenge, or I think it was TikTok, or something, where the groups of people were seeing who could tolerate putting a shot of vodka directly onto the eye. They called it vodka eyeballing. Clever name, I'll give them that, but terrible idea. What do you think you're gonna like get drunk off of putting like hard liquor on your eyeball? It's not. Don't do that. Don't do it. Please don't do that. One more would be eyeball tattoos. All right, injecting dye into the subconjunctival space just underneath the conjunctiva, which is the translucent clear covering on the surface of the eye, injecting tattoo ink into that space. Don't do that. Please. It's not meant for the eye. So that's my don't do that eyeball tip of the week. Keep things out of the eye that are not supposed to be in the eye. All right. Okay, now here's your ophthalmology fun fact. Ophthalmology fun fact. Here it is. Your ophthalmology fun fact of the week. I'm going to keep saying fun until you believe me that this is all fun. Did you know that melanoma can occur inside your eye? as if I needed more reasons to scare you in this podcast, yes, you can get melanoma. And now it's rare. It is very rare. There's about seven cases per million people in certain parts of the country, but it's even less than that in other places. And when I was in Iowa, we saw it a lot, relatively, just because, lots of farmers, it's the Midwest, lots of sun exposure over the course of your life. So you're going to see more intraocular melanoma. But you can get melanoma anywhere that there's pigmented skin, or sorry, not skin, anywhere there's pigmentation, right? In your retina, the back of the eye, it has pigmentation. And so you can get a melanoma that grows back there. All the more reason why every so often you should have a dilated eye exam to look back there, just like you would go to the dermatologist for a skin check, right? Look for any. You should also see an ophthalmologist or an eye doctor, optometrist, anybody that can dilate your eyes and look back there and see if there's any potential nevi, any kind of weird pigmented spot that we need to keep an eye on. Now, again, even if you do have a little freckle in the back of the eye or nevus or some pigmented spot, doesn't mean you're going to get melanoma. Just like you can get those on your skin anywhere, you just have someone take a look at it every so often to monitor for any changes. So that is your ophthalmology. I wouldn't call that fun, but that's for the purpose of the segment. It's an ophthalmology fun fact. All right, now it's time for Explain Like I'm 8. I'm going to eventually I'm going to stop explaining what these segments are, but while we're getting to know each other a little bit, getting to know this segment, it's Explain Like I'm 8, where I have an 8-year-old read me a question that they have about eyeballs or the human body in general. I'm happy to try to answer anything else. That would be a little bit trickier, but we'll see what we can do. We're having an 8-year-old. Specifically my 8-year-old come in, ask a question, and then I answer it in a way that an 8-year-old would understand. All right. Because I think we all could use that for things we don't know a whole lot about that might be a little complicated. Explaining things like you're 8 is not a bad thing. It's just, hey, that's what I do in my content all the time. As I do all these healthcare videos, I'm trying to explain things in ways that everybody would understand without all the technical jargon and things. So here we go. Explain Like I'm 8. Here's an 8-year-old.
What are those red lines in your eyeballs for?
That is a fantastic question. I love this. All right. What are those little red lines on your eyeball for? So those are veins. Those are veins. And you notice that our eyes actually tend to get a little bit more red as we get older, because we gain a little bit more vasculature to the eye. We need a little bit more blood flow, as some of our vessels just don't work as well. And so you notice, you look at a little kid's eyes, they're so white. They're beautiful. They're white. They have no very few blood vessels are visible, just because their vasculature is so robust. They don't need a lot of extra blood flow. They have plenty. And then over time, we get a little bit more red. And whenever we have something wrong, like a conjunctivitis or an infection, our eyes will get even more red, because we have our immune system is we're dilating those vessels, trying to get all the good plasma and things to help heal the surface of the eye. So those little red lines on the white part of the eye, those are your veins. Those are your conjunctival vessels. Now, people do put a lot of effort into trying to get rid of those, because people don't like having red eyes. And I get it. It's not ideal. And this is really the origin of my hatred for Visine, for all things redness relievers. Those of you who have followed me for quite a while, and it just gets me going talking about Visine. I gotta wrap this up, because I don't want to keep you guys too long, but Visine just, it gets me going. I wish we could just package all the Visine into one of Elon's rockets and shoot it off into the sun. That would be beautiful for me. And so but the reason those are no good, the reason you should avoid redness relievers like Visine, Clear Eyes, is because they have vasoconstrictors that will decrease the redness. But then once that drop wears off, the redness, it just comes immediately back worse than before. You get what we call rebound hyperemia. And then you get into this vicious cycle we're constantly using more Visine, more redness relievers, and it's wearing off, and you got to use more and more. You got to treat the reason that eyes are red. So that means probably, going in or starting with just regular artificial tears and or seeing an eye doctor and seeing what's going on. Now, we don't get concerned about redness to the eyes really unless there's other symptoms going on. Now, a lot of people just don't like having red eyes, and I can sympathize with that. But just because your eyes are red doesn't mean there's a problem, because some people just have more vasculature on their eyes. And so if your eyes are otherwise fine, your vision's good, you don't have any pain or discomfort or light sensitivity, you just don't like that your eyes look red, there may not be much we can do about that safely. And it's not something you should be too concerned about. The only way to know is really to go and get checked out. But in the absence of any other symptoms, redness often is not a bad thing. There are certain exceptions. There are certain things that can cause some redness to the eye without symptoms. That's why you also need to just come in and see us and get checked out. But it's often not too much of an issue. But people don't like having red eyes. So I'm going to meet you halfway. Instead of using redness relievers like Visine or Clear Eyes, I would recommend that you use something like Lumify. Now, this is not an ad for Lumify. I have not received any money for this. This is not a brand sponsorship at all. I'm just interested in getting people away from Visine. Lumify is a low-dose brimonidine, which is actually a glaucoma medication. And it's pretty effective at decreasing redness. The one potential downside is that it can cause allergy. And if you get an allergy to it, then you just can't use it at all. So if you want to get rid of your red eyes, like you're taking pictures, you had a wedding, you have an event, something, and you want clearer eyes, then I would use Lumify because it's a safer drop, but just use it sparingly because you don't want to develop an allergy to it because, again, then you got to stop it. So that's our explain like I made. Hopefully I explained that. I may have explained it like you're an 8-year-old, but it wasn't necessarily interesting enough for an 8-year-old, I think. So, there's limits to how well I can do this. Anyway, that's your episode for today. That is Knock Knock Eye. Thank you all once again. If you want to hear about certain topics, or you have questions, or your 8-year-old has a question that you want me to answer, send it to me. Knock Knock Hi, not I. Knock Knock Hi at human-content.com. That's it. Or you can reach out to us through our website, glockandflecken.com. All right. Let me know what you think of these. I'm going to keep doing these eyeball episodes, these Knock Knock Eye episodes. I think they're kind of fun. Let me know what you think. We'll see you next time.